all the studies on sleep will say you're more likely to have dementia, you're more likely to have cancer, you're more likely to have chronic illness if you don't have good sleep.
Welcome to the Dr. Gill Show. This is the show where we talk about medical matters that matter to you. My guest today is Dr. Elizabeth Wilson. Welcome to the show, Elizabeth.
Thank you for having me.
Elizabeth is a board-certified OBGYN doctor in private practice. She has an incredible reputation here in town. And in fact, a lot of my nurses, I believe, go to you for medical care. So you can't get a better endorsement than that.
Wonderful. Thank you.
Yeah, now Elizabeth obviously delivers a lot of babies. She sees a lot of women after they've delivered babies and they're getting on maybe in the next phase of their life, and is growing quite a practice dealing with menopause, hormone replacement, metabolic health, and health optimization in women perhaps when they're getting a little older.
That's probably when women become more interested in what they can do.
Yeah, things don't work like you have to pay a little attention to things.
Exactly.
This doesn't happen. Elizabeth and I also had a departed colleague, Dr. William Trumbauer. Bill was a great advocate of health, and he came at metabolism and thyroid from a really unique and wonderful angle. He was a mentor to both of us, and I can still feel Bill's spirit here, Elizabeth.
I bet he is.
Yeah, it means a lot to us. I get a little teary eyes because he meant a lot to us. So Elizabeth, today I'd like to explore hormone replacement therapy in women, but put it in the broad context of health, metabolism, menopause transition, and explore this a little more. Now, as a reproductive endocrinologist, I'm supposed to be an expert in menopause. And on a test, I still am. I can tell you doses and metabolic pathways and all that stuff. But as a very busy fertility doctor, I've had to focus my practice on just infertility the past few years. I'm doing virtually no menopause work. Things have been changing, things have been evolving, different medicines, different doses, different combinations and all this stuff. I am losing touch with. So I'm so very glad you're here because you're actually doing this type of work.
And I think in the public, it's becoming much more, people are more interested. They're asking more questions. There's actually a lot of companies. There's, people are definitely wanting more hormone replacement therapy, and we're starting to claw back from 20 years ago, that study, the Women's Health Initiative, which kind of came out right as I was starting my practice. Like I kind of went through residency being trained that hormones are good, hormones prevent disease, and we've got this study that's ongoing, and it's going to show us all these good things that we've been observing over the years. Yeah. And then truly, they stopped the study early, and that was a big public brouhaha. And
yeah, that's a good word for it.
It scared women, but it scared doctors. Mm-hmm. And I feel like it's kind of taken this long to really tease out a lot of the details that we need to know from that study. Yeah. And I'd say as a young OBGYN, I was very fortunate to have been in Dr. Trumbauer's practice and actually was put in the same surgery day as him. So when we did cases together, I would hear him talk. And he actually gave me 2 books early on. One was called Screaming to Be Heard by Elizabeth Liette. Uh-huh. And that was just a book about bioidentical hormones. And, and he would talk about the studies in Europe and that how hormones were potentially safer when they were given the right way and the right hormones were given. But this huge study just dominated everything, my colleagues, other doctors. And there were still some women terribly symptomatic who needed hormones, and I felt comfortable prescribing them, because of the the books I had from him. He also gave me a book called What Your Doctor Doesn't Tell You About Menopause by a Dr. Lee.
Okay.
And mostly that kind of helped me understand perimenopause and kind of the interplay of estrogen and progesterone, and the term estrogen dominance, which recently with my study in functional medicine, that's talked about a lot, but it wasn't anything in my training. So that kind of helps me for women that aren't quite menopausal, but they're having, issues before menopause.
Yeah, so let's explain what that is. Menopause is defined as the time around the last menstrual period, and you really don't know it until it's
until a year has passed.
Until a year has passed, so now it's in the rearview mirror.
Correct.
But these hormone changes don't occur at a precise moment. The ovary's running out of eggs, getting fewer eggs are coming up, and sometimes even more will come up. So it's not the number of ovulations; it's more the number that are available. And one of my mentors, Nanette Santoro, described it as when you pop popcorn. In the beginning, they're all popping really fast, and at the end, you get these little scragglers at the end.
I've heard that too.
Yeah, and those are the teeth breakers. Those are the ones that don't pop big. They kind of pop a little bit. They're not the best kernels there. Mm-hmm. So there's this transition time before menopause, poorly defined. And you have to listen to a woman and say, hey, things are changing. And it doesn't happen at a precise age. Every woman ages differently.
Correct. Well, and actually that brings me to think about my very favorite chart, which I may bring out. That I keep this in my office. Hold on here. So
I love charts.
Right here. And this actually, I guess I should correct. Tara Scott is a very very popular hormone expert. She studies a lot about breast cancer and the different kinds of estrogen and how they affect breast cancer. But I stole this from her because it's so helpful to explain to patients the estrogen dominance. Because I usually cover the perimenopause and I explain that when you're fertile, when you're having really regular periods, your ovaries produce these hormones sort of in this ratio, although within a cycle, obviously it's different. You have estrogen in the first phase, progesterone in the second phase.
Right.
When you go through menopause, they both go away completely. But in between, the ovaries are getting tired, and this happens.
Right.
And so you talked about increased estrogen, and then potentially you may not ovulate, so you won't get progesterone, or maybe the luteal cells aren't as good at producing estrogen. And so this flip in estrogen and progesterone is what I think people refer to as estrogen dominance, or at least in the perimenopause phase. And it's funny because when I show people this crazy part of the graph, they go, oh, no wonder I feel so crazy.
That's why my life feels like this graph going up and down.
And so they say with estrogen dominance, you tend to have breast tenderness, heavy periods, and maybe the lack of progesterone could lead more to sleep disturbance, the heat that people feel at night, anxiety, because the progesterone kind of hits the GABA receptors in the brain. And I really, throughout my entire career, I've been shocked at how a little bit of natural progesterone can smooth out the things that women feel are related to this time.
All right, so let me just back up a second and explain this. When a woman is young and menstruating normally and ovulating normally, the woman's going to make estrogen for about 2 weeks of the month, and then after ovulation, she's going to make a strong amount of high amounts of the hormone progesterone, and they work back and forth. Now, in the perimenopause, when these little fizzly ovulations are occurring, they may make estrogen, but these progesterone spikes may not come up. They may not be very long. And like you described, it's a bumpy road, and this normal balance and these normal rhythms are lost.
Yeah. And earlier in my career, I used to try to give progesterone as it would be in cycles, like during that luteal phase. You try to time it to the...
So about 2 weeks a month after ovulation.
But one of the conferences that I attended, in the last several years, a guy, Dr. Wilshire, he practices at WorldLink Medical, but he talked about how just listening to his patients, they felt just much better taking the progesterone every day.
Every day.
And because it promotes sleep, and who knows what's happening with their estrogen production. I mean, it's simpler for the patient, and so that's sort of a way my practice has evolved. I mean, you can always tailor it to an individual and what they need, but that may be a little nuance that you would appreciate.
I like that. Now, let's talk about these hormones a little bit so we have a strong foundation. Estrogen is a very, very powerful molecule. We measure it in the blood, and we're called picograms, just tiny, tiny amounts. And it's called estradiol, and there's a family of estrogen-like molecules. Estrogen comes from, like all steroids, comes from cholesterol, but it works through this pathway, and progesterone's in there, and I won't get into all the details. Testosterone is in the pathway. And then estrogen comes out at the very, very end, super, super powerful. And estrogen, because it's so powerful, you can take it by pill, you can take it by cream on the skin, you can take it vaginally, you can take it by injections, you can take it by patches. There's all these different ways of giving it. And then it gets really complicated when you're adding, well, not just estradiol, but some estrone and some estriol. These are molecules in the estrogen family where it gets very, very complicated and nuanced. And then you have progesterone. It is made 1,000-fold higher as far as actual mass goes because it's not a very powerful molecule. And because you need to give so much, it's hard to get it in. It's hard to get it in. I tell people, people ask me, are you getting too much progesterone? I say, are you drowning in it yet? Well, if you're not drowning in it, you're probably not getting too much. And because progesterone, and we'll talk about the identity, because progesterone, you have to take so much. And if you take it by mouth, your liver chews it up. It's hard to get progesterone in the body, isn't it?
Yes. Although, there's sort of a general thinking that if you're needing it to prevent like estrogen's effect on the uterus, it's best to take it by mouth. That's the only data we have that oral micronized progesterone is the one thing that will, I shouldn't say guarantee, but would prevent hyperplasia or cancer of the uterus, because estrogen's really making that uterine lining grow, like estrogen dominance making heavy periods. So progesterone opposes that. So I'd say oral is probably the preferred way. Now, it can make people tired and groggy. So, giving it vaginally may be I think that's a second preferred way. If for some reason, if people have side effects from the oral progesterone, they can actually use it vaginally, kind of like we do with recurrent miscarriage or preventing preterm labor. That's another thing Dr. Wilshire said that was like, how many years have I practiced gynecology? And he said progesterone is pro-gestation, pro-gest.
And gestation meaning pregnancy.
Yes. And so, and early in my careers, there were women that wanted progesterone for recurrent pregnancy loss. And there was so much hesitance, like there's no data. But I don't know, it's just kind of all come back around. Then there was a study that showed progesterone would prevent preterm delivery. And I feel like I saw that happen in many cases, although I know some of the studies have been questioned.
And they just withdrew it. I mean, this week, they just withdrew it.
I feel like I've had cases where I feel like that's really made a difference from one pregnancy to the next. I have one patient who had classic cervical incompetence at 20 weeks.
That means the cervix gets soft and it expands, and the pregnancy is lost way too soon.
Before viability. And so then she had a cerclage with the next two pregnancies.
That's a stitch around the cervix trying to hold it together.
Yeah. And it was, touch and go, bed rest, bleeding, cramping, treating contractions. Progesterone had come out by the time she was pregnant the fourth time.
Wow.
And she used it, and it was like a totally uncomplicated, it was like a normal pregnancy.
It seemed to make all the difference.
Right. And so, it's hard not to hold on to those things that you've seen,
Now, progesterone is very safe. Now, you mentioned micronized progesterone. Because you have to take so much progesterone, if you take it by mouth, you can't just take a spoon of progesterone. It has to be divided up into tiny, tiny little particles in a special oily matrix that when you take it, it can actually absorb enough to get in the body. So that would be called a bioidentical, because that's real progesterone. Right. Now, because it's so hard, let me just put another finer point on this. Because it's so hard to get enough progesterone in the body, especially when there's a disease or a problem going on, that we will frequently resort to synthetic progesterone. It's called progestins. So when you see pills called Provera or Agestin or something like that, these are synthetic progesterones, because if you want to take them by mouth to get good doses in the body and get through the liver, you have to take these synthetic progestins that are a lot more powerful. But they're not bioidentical. They're not what the body makes, are they?
No. And you know, I feel like for years, the gurus in our society were really downplaying bioidenticals and kind of saying, you know, they're not safe because you're getting them from a compounding pharmacy, or just really acting like, you know, people were recommending something that was almost harmful.
Right.
And yet, you know, and I'm sure the progestins are good when you're needing really dramatic effects for fertility, and that's kind of short.
We need a big hammer,
But like, one of the last things I think to come from looking back at the data of the Women's Health Initiative is, so like obviously one of the things that scared everybody, made everybody stop, and that's still I think in the medical community, is the fear of breast cancer.
Yeah, everyone.
Okay. And I've spent so much time thinking, I have a diagram that I made to try and explain all of this to patients, but you know, about, was it 2006 or 5 or 6 years after the first study came out, there was a little article that said, hey, you know, all those women that were on estrogen alone, the ones who'd had a hysterectomy, so they didn't need the progesterone opposition for the uterine lining, they weren't going to have periods, they weren't in danger of having hyperplasia or cancer. So all they took was Premarin alone. So that's a form of estrogen that's oral and it's not bioidentical. But that group of women had absolutely no increased risk of breast cancer.
In fact, they had a lower risk of breast cancer.
And I believe it wasn't statistically significant, but there have been several other observational studies, whether it's bioidentical, or a lot of them are bioidentical estrogen or estradiol or bias, the combination of E2 and E3.
Right.
And in women who take estrogen alone, there almost seems to be a protective effect. And that flies in the face of the fact that we treat breast cancer with a estrogen blocker.
Right.
And I feel like that's where my colleagues that are practicing in other fields are just like so scared of estrogen causing breast cancer. When, I mean, it happens to be a breast cancer cell is actually a breast cell. So it's going to have an estrogen receptor. And, you know, maybe you can block it from growing once it's there. But if estrogen in your body is helping you sleep better, we know poor sleep leads to cancer. If it makes your immune system better, your immune system can help take out cancer cells. It makes you metabolize your sugar better. You know, insulin and sugar cause cancer. It's like estrogen is trying as hard as it can, I think, to help you from changing that cell into cancer. But once it's there, it could be a problem.
You're making a very, very important point. Now, we're going to have our local breast surgeon expert in Peterson in the coming weeks.
They probably all hate me.
No, we have this fun banter. She'll show me, and she actually brought me over a packet of literature. I was so grateful to her. What a great colleague. Showing, and they're very, you have to pin them down. They're saying in women who are at high risk, who have high risk conditions, maybe estrogen's a bad idea. And they'll show you, but we look at women from enough different population. And I want to back up real quick here. I'm going to put another, say a couple more things about this Women's Health Initiative study that came out. When I was a fellow, I was in Newark, New Jersey, which is an inner city hospital, where they have a much more diverse population. You've got older women, you've got minority women who aren't minority there, and a population that's generally neglected. If you look at medicines over history, it's generally white men they take that are tested. Even women's drugs, they tested on white men. So they were very excited to have New Jersey Medical School there in Newark as one of the test centers. So they could get women from all these different populations. And the results of the Women's Health Initiative was very different, and that's something that you mentioned. It came out in the later years. you can't make blanket statements.
Mm-hmm.
A 70-year-old overweight woman who's been in menopause for 10 or 20 years is a very different woman with different risks from a woman who, let's say, is in the perimenopause and wants to take these hormones, right?
Mm-hmm.
A woman at normal risk for breast cancer is a very different woman from perhaps the woman with dense breasts and family history and all this kind of stuff. So the Women's Health Initiative, it did not make broad brush statement, hormones are good, hormones are bad. You really need to drill down on the actual woman's profile, her needs, and in some women, estrogen, as you can attest, very, very helpful.
Well, and I think what made me start down this path was talking about the difference between bioidentical progesterone and progestins.
Yeah.
And that really there's, going back to the study about estrogen alone, less breast cancer, they're starting to say, it was possibly the Provera or not the bioidentical progestins.
Right. The synthetic progesterone may have been the culprit.
Well, for part of the course through the American Association of Anti-Aging Medicine,
okay,
they do kind of a deep dive in studies of natural progesterone versus synthetic progesterone. And literally in every cell or every part of the body that you look at where progesterone or progestins would do a bad thing, say vasoconstriction or maybe breast proliferation, natural progesterone seems to do just the opposite.
You can't lump them together, can you?
Yeah, and I mean, I feel like it's creeping back into like the regular literature that it appears that risk was due to the synthetic progestin and not natural progesterone, which, I mean, 20 years later, thank you very much.
Right.
But another very good book that I recommend, I don't know that patients really read it, but so Jason Fung wrote The Cancer Code. And that really helped me also realize that, I mean, you can't blame cancer transformation on one thing.
Right.
And so he basically kind of states that, man, we thought when we got the genomic code sequenced, we'd really know and understand cancer. But the problem is, I mean, there are tons of genes for cancer out there. In fact, we're suppressing genes all the time.
Right.
And so what is it that makes a gene finally express itself? And of course, he comes at it from, he's a nephrologist who worked with end-stage renal failure patients, doing dialysis. And so he talks about insulin and blood sugar and how that causes cells to grow and how cancer cells really prefer glucose. And you think there's that insulin receptor that nobody can create a drug to block the insulin receptor. You just tell people to eat less sugar. Nobody makes money on that.
I think this is true with a lot of things, Elizabeth, when it comes to diet, sunlight. You have to look at overall mortality.
Stress.
You have to look at overall mortality. You can't look at a narrow endpoint. You got to look at the big picture to make recommendations, especially in the public health arena.
Well, I mean, and just sleep alone. I can't believe how much of a foundation for health and longevity and quality life that is. I mean, all the studies on sleep will say you're more likely to have dementia, you're more likely to have cancer, you're more likely to have chronic illness if you don't have good sleep.
So I thought when I was a young man lifting weights, and Arnold was the star of bodybuilding and whatnot, and he was a very driven type A personality. He'd say, wake up early, you don't need sleep. And he said, you need sleep? Sleep faster. Which sounds kind of macho and everything, but that's terrible advice.
Right.
You need sleep. You need good sleep. You need deep sleep. And anything that'll help you sleep clearly is huge.
It's huge.
And should not be diminished. So just to go back to bioidentical, obviously arsenic is natural. Red tide is natural. So natural doesn't necessarily mean safe. But I think when we're talking about hormone replacement, if there is a bioidentical or something more natural, maybe that's something to look for. That's something to, if there's a synthetic versus natural, I don't think there's anything wrong with aiming for bioidentical hormones.
Well, it kind of makes sense. And again, back to Elizabeth Vliet's book, from years ago that Trump gave me. It's just like, you know, why wouldn't you put in your body what your body originally made for itself that kept us healthy? I mean, obviously we have tons of these hormones when we're younger. And that's the other thing is like if breast cancer was really caused by estrogen, it would be a young woman's disease.
Right. It goes up with age. Yeah. It's more of an aging disease than anything else.
Well, right. And all cancers are, everything is increased by aging.
Yeah. Yeah. So, all illnesses. So let's say you have a woman in your practice. Let's say she's in her early mid-40s, just not feeling herself, Elizabeth. Tell me, how do you evaluate? What are you looking for in this woman to help her try to figure out what's going on?
You know, I've definitely started listening a whole lot more.
Oh, that is golden. Let me say that, folks. Your doctor needs time to listen. And with these bloody electronic medical records and administrators breathing down your throat that you have to see so many patients per hour and whatnot, listening is a dying art. And for financial reasons, it's being discouraged. They're trying to push the listening down to the physician extenders and whatnot. So if you find a doctor like Dr. Wilson who can make the time to listen to you, that is golden. So I just wanted to put a point on that. So you begin by listening, Elizabeth.
Yeah, well, I from my functional medicine courses, that you know, one of the caveats is if you listen to a patient long enough, they'll tell you what's wrong with them.
Yeah.
And sometimes the story, you know, or when was the last time she felt well, or when did this start happening, or like getting more of a timeline can be, I mean, that's something, I mean, functional medicine doctors, they take hours with their first visit on a patient and they create a whole timeline to
and a lot of these doctors you're paying cash.
Right, no, that's right. This is not in our traditional health system at all.
Right, because people have the means and they have the desire to have a real sit down with somebody to get listened to.
It's interesting how so many patients have an idea what might be going on with it. Like they have these thoughts in their head and
they've been on Google and YouTube as well.
And sometimes just letting them, you know, voice that and hearing, you know, the other thing, like I didn't used to necessarily think a lot about family history or what other diseases was either in the family or in the patient history and like, but how that all is potentially related. All right. You know, the more I've learned about gut health and when I see patients that are.
There's a whole world. Gut health. Oh my
but,
God.
You know,
so important.
If somebody, you know, has a history of some kind of inflammatory bowel disorder or they've been taking antacids forever. You think, oh, there's an issue there. And that's the other thing in the 40s or the midlife, I guess our gut microbiome starts changing as well.
Digestion changes.
And so that's a whole other piece of this. But so I do right now what I kind of so I can keep my office going in a way is I'll do a bunch of labs. And I kind of have experienced, I used to hate doing cholesterol panels. Now I need it. I need to see what's happening with their triglycerides and their HDL. I like to look at a hemoglobin A1C. I look at a full thyroid panel with thyroid antibodies that can tell you potentially about gluten sensitivity with thyroid peroxidase antibodies.
They're linked, huh?
And let's see, did I say and a high sensitivity C-reactive protein, which is very, it's not very specific, but it just kind of might get the patient's attention to start.
It finds that inflammation.
It can be a marker of chronic inflammation. Obviously, if they're sick, maybe it's high, and so maybe you'll want to repeat it. But so what I've realized is that, you know, as we age, you know, obviously when you're 20 or 30, most people you can check a lot of labs and they're all just perfect.
Right.
And specifically, I guess I was initially thinking of like metabolic syndrome and what the definitions of metabolic syndrome were. And at one of the conferences I was at, I decided I could create this chart and chart patients' labs on it. And it's like you never have just one thing that's abnormal. You kind of see things start to get a little abnormal. And it won't necessarily be completely abnormal where a doctor will say, oh, you need to be on a statin for this.
Right.
But you can start to see either blood sugar going up, or if we do fasting labs, I'll check a fasting insulin or a fasting blood sugar. You know, understanding, I think understanding triglycerides and the triglyceride to HDL ratio is really important.
Right. It's not cholesterol is bad. It's these these ratios that are telling you about their metabolism.
So in a way, I'm just trying to like get her to pay attention to like what's going on in her body and like what it could mean. And so I have a lot of various sources, and I probably, I try to find what they would like. If they like to listen to podcasts, this is fun that we're doing a podcast here, but I usually have a podcast or two that I can recommend. And if I have some lab values that might show something specific to that patient, then they're more interested. Then they're going to kind of start learning about it.
And they can watch it at their convenience. And now that you're mentioning, are there any podcasts or doctors or authorities out there with a presence that you can recommend in general?
Well, I actually have little slips in my office that says Dr. Wilson recommended podcasts, and I'm sure the most famous functional medicine doctor out there is Dr. Mark Hyman. And so I have a list in my office of just several things, whether it's the root cause of thyroid disease or inflammation, or there's just one on female hormones, there's one on menopause. I mean, I've got a collection of those. And then somebody else I found, Dr. Kelly Casperson, is a female urologist. She basically
wrote "You Are Not Broken."
Yes. So she is sort of a sexual medicine guru. She kind of got into. She found herself frustrated at not being able to help people with low desire, low libido, and so just obviously a brilliant woman just went headfirst into the data, and then she ended up getting board certified from the North American Menopause Society. So she talks a lot about hormones, and it's not just hormones. It's not just sex. It's a lot of it is just self-empowerment and a lot of, good, mindful. She's excellent. I can't recommend either of them highly enough.
And listen, we're going to put some links at the bottom, at the end of this. We're going to have links at the end of this, and maybe you can show me your slips and whatnot. Okay. We can get those actual links, and we can link them at the bottom.
Love to. But also, I will say that in a lot of my annual exams, when a woman's in her 40s, I show her this graph.
Right.
I kind of try to.
Yeah, that's me. There's noisy waves, random waves is me.
And a lot of it is just acknowledging what somebody may be experiencing.
I'm not crazy.
Yeah. And just, it's like the more somebody understands about what is happening within their body and within their health, that's just, and there's probably a million different paths that someone could go. Not everybody wants to take hormones or needs to take hormones, but like somebody who, really gets their metabolic health under control. I mean, I think it's been shown that those people probably have less symptoms than, people who maybe have other issues. So there's many different levers that patients, I think, can pull with their own health. And it's all about kind of empowering, educating. And I will, Dr. Casperson, one of the things that she has said in her podcast more than once was patients ask her, like, why doesn't my doctor talk to me about hormones? Or, and she's like, we've got 15 minutes.
Right.
She's like,
and 5 of them you have to type.
Right.
Yeah.
And
so you have 6.
So, and she's like, I tell patients, please go buy my book or listen to my podcast and then come back and talk to me.
Right.
And so even though it seems cheesy that I send people away with podcasts, at least it's just, I could stay and talk for another hour or two, but then that's not going to work.
These YouTube things like when a patient calls for an appointment for me, let's say she wants to get her tubes untied. They say, well, listen, go to Wilshire's YouTube where he shows and talks about getting your tubes untied. I mean, we only have so much time, and if you can empower your patients with good information, that's fantastic.
Yeah.
So, getting back to our woman in her mid to late 40s, she's not feeling herself. She's gone to see you. You've taken the time to listen to her. You've looked at her metabolism. You've maybe tuned up her diet, what have you. You've done, and she's doing what she can. Now she's getting into, her menses are really spacing out, or maybe they've stopped, and now she says, Dr. Wilson, I'm getting hot flashes at night. I can't sleep. Sex is now becoming painful. And you're thinking, oh, now she's in menopause, or she's getting close. What is your approach then to a woman with those symptoms?
I ask them, would you be interested in any information on hormone replacement therapy?
Okay.
And most people are, and I've gone through an evolution of various things that I've recommended. honestly, again, I'm back to Dr. Kelly Casperson. She's had 2 recent episodes, the 8 things you must know about hormones and something else, but just, 45 minutes each, to let them listen. I mean, and some people I think have done enough research on their own. I think there's a lot of information out there that some people we can have a conversation about it. I can start somebody on something and see them back in 3 months to talk more about their concerns. I have a list of the American, or the A4M, the American Association of Anti-Aging Medicine, came out with some points from the most recent NAMS statement about hormone replacement therapy. So I review that with them, which, like just things that are better. They say you shouldn't take hormone replacement therapy to prevent diabetes, but it's interesting that women on hormone replacement therapy tend to have less progression to diabetes. And the idea, actually, I was going to say this earlier, but we've been talking about so many things. The idea that transdermal and oral can be very different from a risk profile. Now we think that it's probably best to start hormone replacement therapy as soon as you can, while your cells are healthy, or before your vessels start aging a lot.
Before your blood vessels have gotten real sick.
Right. Because I don't know if you alluded to it, but the other thing that came out of the Women's Health Initiative was the risk of heart attack.
Right.
But that's been, I think we've unwound that a little bit better, and that has to do with the timing of when you take.
Yeah, if you've taken 10, 20 years for your blood vessels to get very damaged, then you take estrogen, you break off a plaque or something, then you've got a whole blood clot in the vessel that you wouldn't have if you might have started in your late 40s and stayed healthier.
And again, we're looking at the Women's Health Initiative data, which taking oral Premarin, which is probably more thrombogenic, like birth control pills or ethinyl estradiol, or, the way you take estrogen really makes a difference. I wonder, because there's good data now to suggest that transdermal estrogen, which, doesn't go through the liver to rev up your clotting factors, that it's either neutral, it may be a little beneficial because you're getting basically anti-inflammatory effects everywhere else. So the idea of using transdermal estrogen, is really a game changer.
It really is. So transdermal, folks, means generally a patch on the skin. It goes from the patch into the skin, into the blood, gets straight to the body without having to go through the liver. And generally, it's estradiol. It's the real thing. It's bioidentical. And so let's say a woman here now, she's getting into menopause. She doesn't have any particularly high risk factors. She's not sitting on pre-cancer of the breast. She hasn't had heart attacks. She's not incredibly overweight or anything like that. Do you have an estrogen that you prefer to start? By the way, we had mentioned Premarin. Premarin is named from pregnant mares. Pregnant mares, and in fact, if you
pregnant mare's urine.
Pregnant mare's urine. That's where pregnant mares make tons of these estrogens. And in fact, if you scratch the surface of a Premarin tablet, you can smell a little bit of horse urine in there. And it's 27 different estrogens in this big cluster of molecules. Now, I'm not putting Premarin down. It has its role, but it's certainly a soup of hormones that you have to take by mouth, which is very different from, let's say, transdermal, which
conjugated
is
equine estrogen.
Yes, that's what they are. So if you were to start, after you look at a woman's, what she desires. Now, a woman may say, you know what, I'm okay with the hot flashes. I'm widowed. I'm not sexually active. I'm not interested in that. And it's certainly okay to say, hey, you don't have to take anything, and respect their wishes. Of course, we're not here to push anything. But if you're going to start an estrogen, are you telling me that you use transdermal estrogen maybe more often than others?
I try to let patients know that there's a benefit to that. And if someone says, put me on the best thing that you think I should have, I'm at a place now where I do a patch of estradiol and an oral micronized progesterone. And that's all, FDA approved, covered by insurance, which is huge too.
It's huge because these medicines are incredibly expensive sometimes.
There's some people that just don't like the patches. And I think it's obviously fine to take it orally because, again, oral Premarin is fine, and especially in a young woman. and some people just like that better. But I try to remind them that if they're going to stay on this a long time, as they get older, or if they have risk factors, if we think they're at higher risk for a stroke or heart attack or something, I think, moving to a transdermal is potentially the way to go.
Right. Now,
and you can also do compounded creams, and that gives you,
yes.
Again, I'm definitely not against compounding, because I think you can really personalize the dose. You can actually add, so there's no, I don't think there's any FDA approval of estriol E3, the weak estrogen, which tends not to cause as much breast tenderness.
Right.
And so, like, if somebody has a lot of breast tenderness with estradiol, you can do a combination. Biased, I think, is what they use, but you can have it compounded however you want. But so, and there's one expert, Pam Smith, who's written several books on hormone replacement therapy, and she's a big believer in using the combination of estradiol and estriol. But I mean, you're getting into compounding, paying out of pocket, and it just, like, I'm working within the conventional medical system with insurance as much as I can.
Right.
But I like knowing what all these other experts say and do in their little, niche practices, just because I can talk about it with people and potentially offer them things,
Right.
Now, the route that a woman takes estrogen can also be dictated by what her symptoms are, for example. Now, if a woman is having painful intercourse but not having much issues with hot flashes or whatnot, we can put estrogen right on the source. You can use a vaginal preparation of estrogen. Some does get in the blood. People think it just stays right there. No, it is a delivery system that can reach the rest of the body, and probably at a high enough dose to at least help bone. People need to realize that estrogen is very good for bone. The biggest problem we've had is that it's so expensive.
And if it's not in formulary, I mean, I'm hearing hundreds and hundreds of dollars for a tube of vaginal estrogen.
Have you tried Amazon?
Tell me about Amazon. But like I said, I'm not doing this very much anymore.
Right.
Please tell me what's going on.
I think, they're like Mark Cuban's pharmacy, Juniper Pharmacy, Excel. There are these pharmacies that are kind of going outside the insurance realm, and they're able to get drugs and provide them to patients, I think, without a middleman for a cheaper amount. And so, like, I'm pretty sure we've used, like, Amazon pharmacy. I mean, for vaginal estrogen, but
really, that's good to know, because some women it's so expensive, or the copay is so high. I mean, it doesn't make any difference.
Well, and I'm name dropping Dr. Kelly Casperson over and over again, not to ride her coattails, but her passion, I think, is like vaginal estrogen. She thinks it should be over the counter.
She's an expert in human
urology
sexuality
and urology.
And so there's a lot of young urologists that I follow on Twitter that are just, singing the praises of vaginal estrogen, that, like, as women get older and have more urinary tract infection, like, there's potentially disease that it could prevent. And it's really thought to be not systemic, like, throughout the whole body.
It's not like taking a pill.
It's a very tiny amount that you use once or twice a week, a minimal amount. And you can, and that's a condition. Now we call it genitourinary syndrome of menopause. A constellation of bladder, vaginal symptoms, painful intercourse, dryness, discharge, itching, irritation, urinary frequent urinary tract infections.
It deserves being called a syndrome.
And it tends to get worse over time. Just every decade for women, it can get worse. And the other thing about it, there's no time frame. Like, you don't have to worry about that 10-year window about the heart problem with heart attacks, because you're not really using it in that amount.
So let's explain that. So if a woman has gone through menopause, has gone 10 years without hormones,
or 30 years,
or 30, so she can probably safely start a low dose vaginal estrogen without worrying about the increased risk of heart attacks that
you really wouldn't even call it hormone replacement therapy. It's just kind of its own topical
local treatment.
Correct.
Fantastic. Now, another thing that I have personally very little experience in is adding back androgens.
androgens. Andro means male, and testosterone is the poster child of androgens. And we all have testosterone in our bodies to some degree. Like I mentioned, estrogen comes from testosterone in women. What are your thoughts about adding testosterone for women? You've started that they're through the menopause, they're in menopause, they're through menopause. You found a good type of estrogen for their hot flashes, genitourinary symptoms. You found an appropriate progesterone regimen for them to protect the uterus, help them sleep, help mood, or whatever that might benefit. But they're still not quite feeling
energetic. There's something missing. Do you ever go into the testosterone supplementation world?
I'm there. No, I'm a pelleter. I put testosterone pellets in patients. So I
Tell
actually
me, that's an injection.
That it's a little implant. Yeah.
Oh, it's an implant.
Kind of like a Norplant or a Nexplanon.
So it's a small
but it's a little
pellet,
tablet, right?
And you'll inject that under the skin yourself,
right? I don't go around just saying everybody needs it at all.
No. I wonder, where do you use it? How do you use it? Where do you use it? When is it indicated?
Okay, so this would take me to another expert who I think she's just amazing. Her name is Rebecca Glazer. She's actually a breast cancer surgeon. And she has written a lot on androgen insufficiency syndrome in women. And there's actually a great article in the publication Androgens. Like, she's written a lot, and I think it was 2020 or 2021. And so she makes a case that, you know, if you think about men and the benefits that men have from muscle and bone, and maybe confidence and mood, you know, just things. That there are some women that when they have more testosterone, they just feel better.
Right.
Now, my experts from the Institute of Functional Medicine and from A4M, they really believe that testosterone is just part of that trio: estrogen, progesterone, testosterone. I mean, and if you look at, you know, the graphs of what women have in their body, 20s and 30s, they literally have more testosterone than they do estrogen.
Sure.
If you just and it drops over time. So you know, they believe that just the cells on a metabolic level, metabolic function, like potentially there are some benefits from probably bone and muscle especially.
Right.
But I don't know that in those smaller doses that they use, and to get back to Pam Smith, like she's a real believer in the salivary testing to make sure these are all balanced in your cells.
Right.
When I check blood work, I'm just looking at what's in the blood. I'm not really testing what's in your cells. But Dr. Glazer feels like you really shouldn't worry about the levels. You should worry about how somebody feels. I do feel like the experts at A4M and IFM are, they would, if someone's tired, they probably think there's something else going on. Like, you need to sleep more. You need to get your stress under control. You need, you know, to.
But if you've done that and you're still not feeling.
I'll correct. And that's where the people who believe in androgen insufficiency syndrome come in. Because, and again, I said, it's good to listen to patients.
Right.
So when I went to my pellet conference in Dallas, so we had a little clinic here in town called Avexius for a while.
Right.
And the laws in Missouri were different from Texas, and they were kind of having a hard time, I think, getting affiliated with a physician to run their clinic. And somebody mentioned my name, and I was like, I'd maybe be interested, but I kind of better check it out first. And so they allowed me to fly down there, and they were having like a training course over the weekend. And, you know, it was the patient testimonials that really got me. Is and even there was somebody who stood up, and a lot of these people work for the company, but a gal who was like, you know, after my second child, I was tired. I was depressed. I just, you know, my libido was down. And
it's called dragging ass.
And it's, you know, throughout my career, that's kind of like, well, yeah, you're a working mom, you're tired, and, you know, you want an antidepressant. And that's sort of our answer all the time. And, you know, this woman was telling her story and just really coming to tears, how grateful she was that when she thought it was her hormones, somebody was willing to give her the hormones that she, which in this
Right.
case, it was a testosterone pellet. And she just felt like it was the answer to her prayers.
Yeah.
And then again, the next day we had a clinic where we were learning to put the pellets in, and this, the company in Dallas, I think they offered their patients like half price if they're willing to be like a guinea pig for this clinic.
Right.
You know, and so these were obviously enthusiastic patients, but you know, everybody that came in just, I just like, I don't think this could all be placebo.
Right,
you know,
right, right.
what the people that are saying that it's changed their lives, or, you know, so I kind of bought into it, and I'm like, you know, there probably are some people who this is really good for.
So you're not going to give this pellet to everybody, but you've screened them for other health problems. You've optimized other things. You say there is still something lacking. You give it. How often does one take a pellet?
You know, they're supposed to last about 3 to 5 months.
Oh, long time.
Mm-hmm.
Long time. And do you measure testosterone levels in the blood, or you just ask them how they're feeling?
We do it about a month after to kind of gauge where they're at, and then yearly. And it, you know, it's hard because I think patients also really, really focus on the level. What's my number? What's my number? What's my number?
Right.
And in my mind, you know, I kind of now think of it as, you know, well, if we're talking about menopause, you know, and you have no hormones, obviously having some hormones is better than no hormones.
Right.
And when it comes to testosterone, I think there's like a basic way of replacing it with the maybe creams and not quite as high. And then the testosterone pellets, we're actually looking at higher levels, say, than you would see that a woman would ever have on her own. I usually tell patients, like, if a woman is normally 5 to 50 and a healthy man, I was saying 500 to 900, but I guess 300 to 900
300
is normal.
to 900 is pretty good.
Yeah. So, but, you know, we're looking at women around 200, 250, sometimes even 300. And, you know, and I will say, I do think that, you know, and that's another, okay, Kelly Casperson hates pellets. She thinks they're pellet mills. She thinks it's terrible. She thinks people are trying to take your money. And I do think that some of the clinics don't explain to patients what exactly we're doing with the dosing. Like, I don't think patients always know, like, they just think, oh, I had none and now I have what I need. But it's like, you know, you're actually way more than you've ever been before.
Right.
And this is kind of like a tweak or a hack, and I make it really clear to patients that that's what we're doing. And I probably, when patients come in, they probably think I'm trying to talk them out of it the first time, because I just, and I tell them to listen to Dr. Casperson. This lady hates pellets. Listen to what she says about it. But so I try to just put all the information out there so that people can really kind of find their own way and see maybe what they need.
And do these women have much hair growth or acne or oil or skin symptoms?
I'd say probably acne is the biggest problem. And, you know, sometimes lowering the dose, spironolactone is, you know, a common medication for acne in general, and it works pretty well with the testosterone pellets.
Okay.
You know, you might worry a little bit about male pattern baldness.
Mm-hmm.
I'd say I was able to communicate. I emailed with Rebecca Glazer, the woman that I talked to. She's in Dayton, Ohio, the breast cancer surgeon who does the testosterone pellets. And actually, she uses the testosterone pellets for a lot of her patients that have had breast cancer that can't use estrogen.
Right.
Thinking the higher doses of testosterone. I mean, there's a little bit of conversion, obviously, to estrogen.
You're not giving estrogen, but you're giving estrogen.
But she said in her experience, she doesn't see a lot of problems with hair loss, that it's mostly acne. And she actually has pellets that, I think some of them, she has them made with spironolactone, and she also has some made with, I think, the aromatase inhibitors. So
Interesting. Advanced compounding.
Yeah, right.
Wow.
So, and that would be...
That's why I'm so glad you're here. I don't know anything
about that cutting edge formulation.
Well, and she has a website. I mean, she doesn't do podcast. I mean, she's very clinical, and I'd really love to go visit her sometime. But she had the article in Androgens that I mentioned. It just testosterone pellet therapy in women, and I think her whole community, like the oncologists there, like everybody's on board with her, and she has some really happy patients.
That's fascinating. Now, I had a personal experience with a woman who came to me. She was very athletic, wasn't feeling herself. I did some hormone tests. They say, hey, your testosterone's in the normal range for a menopausal woman. And she still wasn't feeling good. Now, because I don't have training I don't know how to monitor testosterone pellets. I have no experience with it. She went elsewhere, got a testosterone pellet, got her testosterone from like 40 to 200. Now she feels wonderful. Mm-hmm. And I'm so glad she does.
And I don't know whether to say it has long-term side effects and problems that are going to outweigh her current well-being. But if she feels better right now, that's got to be valuable.
Well, where I've sat with this is that I think, when women are creating babies and growing babies and feeding babies and, your estrogen and progesterone have to do their thing. They have to cycle. You have to ovulate. You have to, having too much testosterone while you're trying to care for your young probably isn't a good idea. And obviously you don't want to get pregnant while you have a testosterone pellet in. That's bad. So,
sure.
Birth control is kind of a big thing if someone's doing that at a younger age.
That's an important point.
But if men can have that, right? And they do fine. And Dr. Glazer from Dayton, she says, testosterone doesn't make you bleed. Testosterone doesn't make your breasts hurt.
Right.
Like it's not bothering those female organs that we have to deal with and that we have to put up with all the ups and downs so we can do this wonderful thing of bringing children into the world. But when you're done bringing children into the world, why not maybe have a little bit more? And I guess there is data on, people who transition, who take testosterone. And to my knowledge, there's no problems with that physiologically, or that there's no increased risk of cancer or problems. And I think in general, society supports people that want to do that to feel better.
Right.
So another thing, again, I said sleep. And even if you're happier, if your relationship is better, again, so there's a podcast that Dr. Hyman does with Kara Fitzgerald on methylation. Getting into a whole other gear here, but they talked about how cuddling improves your methylation, and so methylation is in this case is referring to pretty much how your DNA is transcribed. Like we were talking about cancer, that everybody has genes for cancer, but it comes at a certain age. Why does it come at age 50 instead of age 5?
Right.
And so one of the things that people study is biological age through DNA and the methyl groups that are on the DNA. And the idea that cuddling improves your methylation, or
you can actually measure that.
Yes. Yeah.
Now, so methylation, methyl groups stick on DNA and can turn it off in myriad different patterns and ways.
Correct.
Regulate.
And so it's when, again, listening to patients, or these patients that do come back that are on the testosterone therapy, when they say, this has just changed my life. My family has noticed it. My relationship is better.
Sure.
If someone's relationship with their family or their husband gets to a really good place, and I think there's a lot of physiological benefits that, we don't necessarily, Kara Fitzgerald can measure it in biological age and methylation, but there's just a lot out there that patients know about themselves, that it's good for them.
Yeah. So I'm not an expert on long-term safety issues, but certainly the benefits in the right people. If you ask high school athletes or college athletes taking testosterone and whatnot, say, if this is going to take 10 years off your life, but you're going to be a superstar on the field, most people say, I'll take the superstar and I'll take the loss at the end. So whether that's the best thing to do, I don't know, but certainly have to weigh risks and benefits. And if there's huge benefits up front for at least some women, I guess it's hard to argue with.
Well, and, again, bringing back to Dr. Trumbauer, every now and then I get to see some of his patients that have stayed on his hormonal cocktails.
Yes, I still see some.
And the ones on hormones, the ones on testosterone, are doing, I mean, some of the best bone density scores I see are on these women that have been taking testosterone for a long time. And I, again, that we don't talk a lot about muscle health.
Yes,
right?
but the stronger you are, less likely you are to fall and get that hip fracture, for example, that wrist fracture.
And the better you are probably metabolically aging as far as, maintaining your blood sugar levels and lowering inflammation, like having more muscle tissue.
Having more muscle, it's active.
And there's Gabby Lyons, do you know who she is? She's a muscle centric.
Okay.
She has a podcast too. She just talks about the key to aging well, and I guess it's probably if you get up to 80 and 90, it's like you want to maintain your muscle, you want to maintain your bone.
Absolutely.
So my hunch is that it overall is going to be healthy.
I hear you.
So.
I hear you. Now, being a fertility doctor, I just want to go off on a little tangent here. There are so many doctors that tell men, the men comes in, hey, my testosterone is low. You were talking about the counseling you should give these patients before they take a hormone. I see this all the time. Men are not counseled, or their doctors don't even know that if you give testosterone or testosterone derivatives to a young man, it will crash his sperm. It is a contraceptive. So your testosterone is low. Let's give you some. It will crash your fertility. So I just wanted to throw that in there in case guys are listening. Say, hey, maybe I should take more testosterone too. Don't do it if you want to have babies,
right.
guys.
Fertility's huge.
Fertility's huge. That's obviously my world. So I just wanted to throw that out there.
Yes.
Are there any other
ways to take hormones? Now, estrogen is given by patches. You get good doses. And the new patches, really, they're not so new anymore. They really stick really well, don't they? But they can still peel off. You sweat too much. It's hard to get. Do you have much experience with creams or gels for transdermal estrogen?
So there are some gels that are FDA approved, although I talk a lot with the compounding experts at Kilgore's, and
that's a local pharmacy that works with us. Yes,
and I think there tends to be more irritation with gels, and you can't quite get as much, so you need more of it.
Okay.
And fortunately, inheriting a lot of Dr. Trumbauer's patients, but trying to fine tune the estrogen again, like someone having breast tenderness, if I want to use that other estrogen, what we call E3 or estriol for less breast tenderness, that's a real easy thing to try and use the creams for. And then again, there are some women that maybe want to take testosterone, but they don't want to do a pellet, and then you would do a cream.
And they can compound some testosterone in there as well.
So, I mean, Kilgore's is just amazing and out of this world. They make a cream for me that I used to practice at the Family Health Center, and I wanted to get some Mycolog cream for somebody. That was like an antifungal and a steroid cream, and that used to be like my fix everything cream. If I didn't know what was going on, I mean, it wasn't yeast, it wasn't BV, or there wasn't something that I could diagnose.
Rub this
but
on.
just
Tussin.
If someone's having irritation,
Windex,
like this was my go-to, and but it was kind of expensive. And so, and I, with the Family Health Center, Kilgore's would really work with the Family Health Center to have certain medications available at lower cost. I mean, it was like they just were this caring pharmacy that was like helping the community. And so I called to say, do you think you could like make up a similar cream with an antifungal and a steroid? And then I said, hey, and can you add some estrogen?
I love it.
And so that became my new so anyway, if you have an idea or they really can work with, more of an approach to individualized medicine. And then they also made a probiotic cream for me.
Wow.
Where one of the functional medicine podcasts was talking about recurrent urinary tract infections. And one of the tricks that they were to try to break the cycle of like always using antibiotics, they suggested using a probiotic cream like around the urethra to kind of flood the urethra with lactobacilli.
The healthy bacteria.
And so, I called Ann at Kilgore's. I'm like, hey, have you heard of this? Can you do this? And so they're like magicians. So, and I think, again, I know there's a lot of negative talk about compounding pharmacies, but when you really want to individualize something for somebody, there's just nothing like it.
Yeah, yeah. So there's different ways to take these various hormones. It is a complex minefield. You need a doctor who has experience, who can give these things to you safely and whatnot. And certainly someone who has active experience. For this, I'm very grateful to have you here in the community, Elizabeth. Like I said, my nurses and friends use you as their personal doctor, and your reputation here is just wonderful. So I want to ask you, will you please come back sometime?
I'd love
so
to.
we can talk about these other functional medicine issues, aging, anti-inflammatory issues, metabolic issues. Maybe we can drill down into the confusion around cholesterol and inflammation. I would love to chat further with you.
I would love that too. I just even, at some point I realized that menopause was kind of like polycystic ovarian syndrome, like the similarities
there are
of
some.
insulin resistance. And
Right.
and I'll say, way back in the day, I remember just being so impressed. Patients who would go to you and start on the Dr. Wilshire diet
that I stole from Atkins and gave people.
It was amazing. People would get pregnant just based on what they were eating.
I love that. Those are my greatest success stories.
It's like all these things. It's like it's just been building. And you brought Gary Tobbs to talk to us.
Okay, I brought Gary to town. He's still a friend of mine. Yeah. We'll hopefully have him on the podcast eventually as well.
Oh, that would be cool.
Yeah. I'm going to be developing a video link, so I don't have to fly everyone in to interview here. But we'll be branching out and talking about with all these wonderful people out there. So Elizabeth, thank you again for your time. I've learned a lot from you, and I really appreciate you coming on the Dr. Gill Show.
Thank you. I've learned a lot from you too.